Good morning, good afternoon, good evening, everyone. Thank you for joining us for this webinar. My name is David McCoy. I'm a doctor by training and background. Moved into public health after about 5 or 6 years of work as a clinician. And I now work with the United Nations University International Institute for Global Health, which operates as a think tank within the UN system. In a moment, I'm going to hand over to my colleague Abe Shukla to introduce himself and moderate this session. But before I do that, I want to make 3 points to set the scene for this webinar. The first point concerns the term financialisation. Much of what we're talking about relates to this word. It's a word with a history and a meaning that really needs to be better understood in the health sector. The definition that I like to use for this word financialisation is the increasing dominance of financial actors, financial markets, financial practices, measurements and narratives, alongside fundamental structural transformations that see public institutions, communities and individuals, and also companies and businesses become subordinated to the interests of financial capital and the financial industry. So that's a bit of a mouthful, but nonetheless, it's a good, succinct description of what we mean by financialisation. Here at UNU-IIGH, we are concerned about financialisation's impact on health. We see across the world examples of negative impacts on patients, on health workers, but also on the health system as a whole. So our concerns are about ensuring that there is enough awareness of these negative impacts and that there is enough regulation to prevent them from happening. Now, we are aware that there is an argument being made that private investment in health can help catalyze economic growth, can help grow the GDP of countries, and that this will then provide health benefits. That's an argument that also needs to be interrogated carefully. The second point I want to make is to further contextualize this webinar by noting the fact that over the past 3 decades, we have seen across the world the amount of private wealth relative to public wealth grow. Across the world and in most countries, private wealth has grown, but public wealth has either stagnated in absolute terms or it has actually decreased, both in absolute and relative terms. Now, it would be one thing if this growth in private wealth was distributed equally. The reality, of course, is that much of this private wealth is concentrated in a tiny number of hands. It's been estimated that between 20 and 30 individuals, for example, own as much wealth as the bottom half of humanity. The other thing about this concentrated private wealth is that it is also managed by a small number of private financial institutions, asset management firms, private equity firms that manage this concentrated private wealth with the explicit intention of investing it for the purpose of generating double-digit returns on that investment. So this is part of the context in which we are discussing private investment in health and healthcare. I want to end just by making a third point about the public-private dichotomy. We often talk about public versus private, and the point I want to make is really that this dichotomy is oversimplistic. When we talk about private actors, we must really be a bit more specific about the type of private actors. And similarly, when we talk about public actors, we must also talk about the type and the quality of those public actors. Ultimately, our concern is that financialization and public-private partnerships and public-private mixes serve the public interest and reduce health inequalities across the world. So with that, hopefully useful scene-setting 3 points, I will now hand over to Abe. Abe, the floor is yours. Thank you very much.
Thanks a lot, David, for giving an introduction. And I welcome all of you, all the participants and the panelists for this webinar. on basically financialization and corporatization of healthcare, an Indian case study with global dimensions, which we have titled When Extractive Finance Reaches the Hospital Ward. So in this webinar, which is being co-organized by the United Nations University International Institute of Global Health and the People's Health Movement, we will be discussing two papers which have been recently finalized. And the authors of these papers will be presenting the key findings from these papers. I'll introduce the first. So the first paper is on analyzing globalized financial investments and corporatization of private healthcare in India. I think everybody who has registered would have received this paper. And the second paper is on effects of corporatization on practices in private healthcare institutions, from the viewpoint of healthcare professionals. So these are the two papers which have been also put in the chat. So you're welcome to see these papers later on also. Given the necessarily restricted time, we will not be able to discuss in great detail all the findings of the papers. These are very rich papers. I would encourage you to read these later, or if you've already read them, you would be aware of the range of issues that we have tried to cover. But we'll be briefly presenting both these papers, followed by one round of clarifications. Not necessarily a very in-depth discussion in the first round, but any clarifications about the papers itself. And then we'll have two more speakers who is so I'll introduce them before the next round, who are Leonardo Matus and Anna Marriott, who will be coming in with the global perspective and the perspective from Latin America and Brazil, also commenting on financialization and corporatization of healthcare. So I think we will now go ahead. Yeah, I think my brief introduction has been put in the chat box, so I don't think I need to introduce myself, but I am a public health researcher and associated with the UNU-IIGH and also with the People's Health Movement. I think now we'll go ahead and start the series of presentations. And for whatever questions you may have, please note them down. And after we finish the presentations, please put them in the question and answer box, not in the chat box. The chat box is for some general exchange. But if you want a question to be addressed, please put it in the question and answer space. And then we will respond to all the questions, or as many as possible, which have been put in the question and answer space. So without any further delay, and again welcoming all of you, we will go ahead with the series of presentations. So Professor Satiki Roy, he's an economist. He's an associate professor in the Institute of Studies in Industrial Development based in New Delhi. He has done extensive work on various aspects of developmental economics, and he is one of the co-authors of the first paper on patterns of financialization and financial investments and corporatization. So Satiki, please go ahead and start your presentation.
So thank you, Dr. Abhay and Dr. David and my co-panelists. This is a very important discussion, and what I'm going to talk about is a part of the paper which myself, Professor Indranil, and Sonia, three of us have worked on this particular aspect. So I'm going to present on their behalf that part of the paper. This is on corporatization and financialization of hospitals in India. Next. So basically what I'm trying to do is understand corporatization and financialization, but which is part of a larger project, which is neoliberalism, which is nothing but a creation of a market society. And it should not be understood in a restricted manner that the state is just withdrawing from the realm of production, but actually it takes deliberate action to create private players, to create market as the major distribution system, not only in other goods and services, but it advances to the realm of social reproduction, which includes health and education. And it is done through decentering, a kind of fragmentation where you create multiple property rights in different levels of healthcare services, public and private. So you create different players who would be acting upon the market. In case of India, we'll see that there has been a rise in middle class demand uh, for our for premium healthcare, for luxury healthcare, which was a pent-up demand which was released during the process of liberalization. And on the supply side, we'll see that there were non-resident Indians who were waiting to invest in this highly profitable sector, which emerged as a profitable business, particularly with the advent of neoliberal policies. Now, the process of this fragmentation and also the creation of this market society involves two contradictory processes. One is the horizontal consolidation, which is required to achieve scale economies. And the second is the vertical consolidation in a regime of managed care where the government, the insurance companies, and the big hospitals, they interact with each other at different levels. Next. Now, what I would try to do, first of all, uh, make a little bit talk about corporatization and financialization, what we want to mean about that. Now, the definition of corporatization basically comes from Paul Stur's famous work in 1982, which is once again reflected by Erin Brown's recent work in recent paper in 2025, where they define corporatization as a movement from non-profit and government organization to for-profit companies. There is a process of horizontal consolidation, as I mentioned, of locally controlled entities to nationally or regionally controlled corporations. There is a shift from single unit to single market and single market companies to conglomerates. There is a vertical consolidation, which I mentioned, and also increasing concentration, size, and scope of organizations. So basically, we see centralization and concentration of capital in the health sector as well. The definition of financialization basically comes from the post-Keynesian literature, who see financialization as a shift from retain and invest to downsize and distribute. Basically, it tries to maximize shareholders' return. It assumes prime importance against the stakeholders, say the doctors, the patients, and the healthcare workers. They get lesser importance in this strategy. And also there is a rising dividend and interest payment, which is very important, which I will show through figures, even in hospital sector, which increases the distributed profits and therefore reduces the finance which is required for long-term investment, particularly in capital stock and machinery and other things. So increasing relevance on financial as compared to real investment, that becomes a critical feature of this financialization process. Next. Now, if we see what is the background of this process of financialization, one is there is a rise in the demand for healthcare services. We see in this figure that there is an increase in private final consumption expenditure of households on healthcare, primarily because of awareness of health issues, and also because of rising per capita income in India. And the most importantly, because of the shrinking of public provisioning of healthcare. So we'll see that the healthcare expenditure has increased much faster compared to other consumption expenditures in India. Next. Now, here is the sectoral composition of healthcare private equity and venture capital investment for a longer period from 1998 to 2024. We'll see that in the healthcare and if you see that in life sciences, the major investment that has taken place is pharmaceuticals and hospitals, who account for 63% of the total investment in health and life sciences. Next. This shows that even if the investments are coming, they're very much concentrated in particular regions, major concentration among prosperous geographies, where we'll see basically metro towns. 77% of investments are in entities located in 6 cities: Bangalore, Manipal, Delhi, Hyderabad, Mumbai, and Pune. These are the major cities who have attracted this investment. Next. Now, this shows the investment of foreign direct investment, which were basically started from 2000 when the government allowed 100% FDI in this sector. Generally, drugs and pharmaceuticals usually used to attract for FDI, but it has increased in healthcare sector, particularly hospitals and diagnostic sectors. We'll see 17, 18, 18, 19, and 19, 20 at the 3 years, where the major share of these segments have increased in total FDI coming to the health sector. And that is primarily because of the introduction of Prime Minister's Jan Arogya Yojana, which is a scheme which actually expanded the demand for healthcare services and which was announced in 2018. Probably that attracted FDI in these segments. Next. Now, this shows the top 80% deals in hospital sector of post-COVID, which is, once again, you can easily find that these are the metro cities and these are the investors who actually invested in this healthcare sector. Next. Now, the investment profile basically shows that 209 investments covering 88 hospitals, of which 91% of the deals involve unlisted companies, 69% are private equity, and 31% are venture capital investments. Roughly 1/3 of the investment are single specialty hospitals, of which 48% are venture capital, remaining 2/3 are multi-specialty hospitals. And out of 88 hospitals to have received PEVC investment during this period, you can see the names: Manipal Care, Max Healthcare, Sahyadri, Medanta, Agarwals. They are the major recipients of this investment. In the post-COVID period, 38 investment deals took place in hospital sector. Top 8 deals constitute 80% of the investment, and 17 constitute 90% of the total investments. Next slide. Now, this shows the growth of mergers and acquisitions, the number of merger and acquisition deals that happened in the past 2 decades in the hospital sector. We see that it is increasing. Next slide. This basically shows that we have, using the CMI Private database, we have identified 274 hospital companies, which are basically listed companies. And we'll see the data of top total 274 companies and top 100 and top 15 companies. What I want to highlight is that the growth of sales increased for all segments, of course, but the growth of profit has been much higher than the growth of sales, which basically indicates that a part of the profit was not coming out from the sales of healthcare services, but basically from financial resources and financial channels, which is important for this discussion. The growth of profit has been highest on average for top 15 companies, which is important. And most importantly, we'll see that during the COVID period, we'll see that top 100 and top 15 companies, they recorded very high growth in profit, while for the total sector, the growth of profit was negative. So it is the big players who actually gained out of this system. Next. So this basically shows the income from financial assets with respect to sales, which has increased over a period of time. It increased till 2013-14 and then shows a decline. This is important because it shows that the signals of financializations are quite evident in Indian hospitals, where the reliance on financial assets in terms of generating income is increasing with respect to sales. Next slide. And this is the last slide where I basically try to show that if you see the financial expenses out of total expenses of top 15 hospitals, these are the big hospitals, that is increasing. That shows a steep rise. And this steep rise actually shows that the financial expenses, if higher in the total expenses, then the part which is left for investment in fixed assets, that actually declines. So financial expenses, which are basically going toward distributed profits, that include fee-based and fund-based payments. And if these payments increase out of the total expenses, then of course it is going to the rentier incomes, and that actually reduces the internal finance for real investment, which is the key feature of financialization. I'll stop here.
Thanks a lot, Dr. Satyaki, for finishing in time and giving a very comprehensive uh, presentation. And as we have seen that the flow of financial investments over the last 2 to 2.5 decades has been accelerating and has increased substantially in the hospital sector, not just in the pharmaceutical sector. And different aspects of these patterns of this investment have been made clear. And now we'll immediately go to the next panelist, which is Indira Chakravarti, who is a public health expert. She's an independent public health researcher and also a visiting faculty in Ambedkar University in New Delhi. And she will now speak about the second part of the paper, which deals with case studies and development financing institutions and the impacts of the financialization and corporatization. Indira, please go ahead.
Thank you. Thanks, Abhay, David, everyone. So what I will be doing is to put some names to all these numbers that Satyaki has just shown us. The next slide, please. Often in India, corporate hospital connotes many of the names that Satyaki has already mentioned: Apollo and Fortis, Max, Manipal, etc. So corporate hospitals is related with these big names, and also related to the fact associated with them being located in metropolitan cities and catering largely to affluent domestic and international patients. Now that while it is a good description, still it remains a very limited description because it misses the larger transformation and reconfiguration that has happened in the private healthcare sector over the past 3 decades, since the late 1980s. Which, for those of us from India, it would not be very erroneous to call it a kind of a company Raj in healthcare coming in, where it is now common sense that hospitals ought to function as businesses. Investment in hospitals has become a big business opportunity. And this has been, it is important to understand how this has affected the hospital structure and the behavioral changes within hospitals also in setting up of hospitals, commensurate with conducting healthcare as a business. So that is another way with which we have approached corporatization too, namely structural and behavioral changes within hospitals, that enables them and that has facilitated them to function as businesses. Next slide, please. So while big names, having said all that, big names do still matter because they have been the early ones have been major influencers. As I have shown here, Apollo is among the early big private corporate hospitals incorporated in 1983. It now calls itself as it has been a very important early influencer. It describes itself as the largest integrated healthcare organization in India. Next slide, please. So what that means is, on the ground, Apollo now has institutions, healthcare facilities across every segment of healthcare. As we in public health would say, from primary right up to super specialty. It has a number of not only super specialty hospitals, but multi-specialty hospitals, often called Apollo Reach hospitals, branded as Apollo Reach, a large number of multi-specialty clinics providing outdoor care. I've shown here from diagnostics to IVF to dialysis centers, a very large number of Apollo pharmacies, which are a very big source of revenue other than hospital care. And also in healthcare, Apollo has a number of facilities, not just medical colleges, but also schools of nursing and Institute of Hospital Administration, as well as research. Next slide, please. So in all, currently Apollo has 73 hospitals owned subsidiaries, joint ventures, but also managed hospitals. That is something we can discuss later. The hospitals concentrated in the southern area, southern states, but also in the rest of the country. So that's one thing when we say pan-Indian hospitals, we have several of them. It's important to note that together then it has over 70,000 employees, all related to healthcare and as well as overseas operations also. It has entered into an agreement with healthcare group in Indonesia. Next slide, please. If you look at the investment pattern, again, these are all from the annual reports of Apollo. 30% owned by the founder, the promoter, as they are called in India, Dr. Pratap Reddy and his family, and the remaining a large number of domestic as well as foreign institutional investors, including IFC. The others, like IHH, the sovereign wealth funds from Singapore and Malaysia were prior investors. And next slide, please. Now, again, as I have been repeating, it's not enough to look at these very big names. What has happened out, over the past 3 decades is we also have a very large number of smaller regional companies too. It's not just these pan-Indian companies, but also regional companies in smaller cities. And also hospitals of all sizes are now being set up as for-profit hospital companies, whether they are from the tertiary to the primary level or single specialty hospitals, Rainbow and Cloud9, etc., in oncology, from oncology to dialysis to diagnostics too. Next slide, please. So this is to, I just wish to, give an idea here. I mean, the southern part of the country is not shown. This is just to highlight the fact that these are some of the regional companies that are slowly expanding across the northern and eastern states of India, which are the relatively poorer states. But even there, we are seeing that several companies are spreading. And one point to be noted is that many of these hospitals are also acquiring the smaller single doctor owned hospitals, something which Satyaki had mentioned. So that also needs to be noted, this whole mergers and acquisitions of smaller hospitals. Next slide, please. So this is another example I have put of a multinational diagnostic laboratory chain also that I mentioned. Thyrocare was one of these early diagnostic companies which now started what is called the hub and spoke model of regional laboratories and a very large number of collection centers spread across the country. As you can get an idea from this map here, it also has a presence in Nepal and some of the Gulf countries. And in diagnostics also, there is a similar pattern of acquiring smaller pathological laboratories. And there's also specialty diagnostic setting, diagnostic laboratories in genome testing, etc. Next slide, please. So last 2 points. In terms of investors, right, you have private equity and sovereign wealth funds, etc. But one should not miss sight of the very, very important influencer and actor, which have been the development finance institutions of these countries I have mentioned here. But it is important to highlight the role that has been played by the IFC, the International Finance Corporation, a World Bank institution. IFC, along with World Bank, has played a very important role in the structural reforms. And IFC has initiated investing in private hospitals. It gave this argument that IFC investments will have a demonstration effect and will encourage other PE funds and financiers to invest in the private healthcare sector. And this has to be kept in mind when we see what has been happening. Next slide, please. The performance, there are reports are available. Even in India, studies have been done. It's important to see what has been the performance of these DFI financed hospitals, patients' rights violations, not providing free healthcare, and absence of transparency. Also, if we bring in the labor conditions, also the conditions of doctors and nurses, that also needs to be kept in mind. So overall, doing more harm than good, and not really delivering on what was promised. So next slide, please. The last one. It's important, therefore, to also understand the impacts of this kind of financialization and corporatization that has unfolded over the past 3 decades. Extractive and corrosive impact. There's been major rise in treatment costs, over-medicalization, and simultaneously neglect of primary and preventive health care that has been undermining public health outcomes, very inequitable health care, the impact on the doctors and healthcare workers themselves, which will be dealt with later. We've just put it in here. The expansion of private commercial health insurance is something that needs attention, as also the whole role of digital technologies. Financialization has been enabled in a major way by availability of digital technologies. So that is something that needs attention. Lastly, the entire social disembedding of healthcare as a public good, which was referred to, so healthcare now as a commodity. These are all the major issues. So I will stop here. Thank you.
Thanks a lot, Indira, for completing the second part of the paper. And as all of us can see, that there's a lot of information to be presented. There are several other case studies also, but because of lack of time, you could present just a few of them. But I think a very important point which has come forth is that it's not just the big names that we know about, but the process and the phenomenon of corporatization has spread across the board, across multiple levels of healthcare, across various geographies, and with a great diversity of investors also. While private equity and venture capital are perhaps somewhat better known, but there are a whole range of different types of investors who have, including many different types of domestic investors who are also now investing in the corporate healthcare sector. So since following on your last slide on the impacts, now let's move to our next panelist, which is Dr. Anand Zakaria, who is a professor at the Christian Medical College, Vellore in Tamil Nadu, and who is himself a practicing physician and also an active member of the Forum for Equity in Health. And he will now present the second paper, which is on the effects of corporatization on practices in private healthcare institutions. So while the first paper has looked at the macro picture, the second paper looks at the entire situation from below. What are the impacts that corporatization is having in hospitals in terms of management practices, clinical practices? How are healthcare professionals, including particularly doctors, experiencing this entire process? So Anand, please go ahead. You need to unmute yourself.
Am I clear now, Abhi?
Yeah, I can hear you.
My presentation is on the effects of corporatization on clinical practice, the experiences of health providers in private hospitals in India. I will be presenting on behalf of the Forum for Equity in Health, which is a collective of young health professionals who are working towards equity in health. Next slide. As we have already heard, there has been a shift from public to private healthcare in India since the 1970s, and the rise of corporate hospitals, particularly since the 2000s, which have impacted on clinical practice in the form of revenue targets, managerial control, and reduced clinical autonomy, leading to higher costs and reduced access to health care. There's also been the simultaneous privatization of medical education. Next slide. So our aim in this small preliminary study was to ask the question, how is corporatization affecting healthcare workers in private hospitals and the practice of medicine? Next slide. So we used the methodology of an exploratory consultation with the doctors and nurses, each of whom had interviewed 3 to 5 persons who were working in private hospitals. And the theme of the consultation was how corporatization shapes everyday clinical decisions, relationships, and the response of healthcare professionals to this. And we conducted a thematic analysis of lived experiences based on this consultation. Next slide. From the consultation, we identified 7 main themes. The first is of market logic and erosion of clinical autonomy. We found that there were managerial priorities overrode professional judgment. There were fixed prices and standardized revenue-driven protocols, and doctors were restricted from discussing costs or alternatives. The leadership in foreign-funded and multinational hospitals were inaccessible, and clinical staff had no channel to influence policy. 2 quotes were that the administrators said, "The prices are fixed by us, you work for us." Another, "It is more like a market. We are the provider and you are the consumer, whether you want it or not." Next slide. The second theme was of target-driven culture, the emphasis on numerical performance indicators, pressure to maintain high intervention volumes, financial incentives tied to targets, job insecurity for underperformance, and managers lacked clinical background, widening the disconnect with clinical staff. 2 quotes were, "There is a constant monitoring of the income of each hospital, department, and what the doctor generates. If they did not meet their targets, they would receive warnings every 6 months." Next slide. The third theme was of overuse of procedures and diagnostics. High-cost tests were normalized. There were unnecessary surgeries such as cholecystectomy and cataract, and patients were not informed of alternatives. 2 quotes were of a neurologist who advised thrombolysis even when it wasn't indicated. Health checkup process was a fishing net. Examples of overuse of procedures were routine full-body scans as part of checkups, MRI cholangiograms before gallbladder surgery, whole-body CT scans in trauma cases instead of a fast ultrasound. Next slide. The fourth theme was of high costs without quality. Costly medicines are advocated when there are less expensive alternatives. There were unnecessary admissions. There were referral incentives and cost-cutting measures such as staff shortage and high turnover of staff, all of which led to compromised safety. A quote was that there was private sector pricing with public sector levels of apathy. Next slide. The fifth theme was on the impact on health professionals. There was widespread evidence of moral distress and burnout, of exploitation of junior doctors and nurses who were working in precarious conditions, and institutional bias towards high-earning clinicians. 2 quotes were, a nurse said, "I lost my emotions. I even completed my shifts without knowing the names of the patients." Doctors either reconcile with commercialization or leave disillusioned. Next slide. So there was also evidence of resistance by health professionals in the form of informal accountability initiatives. For example, in the hospital where a person was doing unnecessary thrombolysis, the colleagues formed a WhatsApp group to monitor unnecessary thrombolysis. Some clinicians adopted part-time roles as a way to uphold ethics And despite all the evidence of privatization, there continued to be empathy despite systemic pressures. Next slide. The last is the effects on medical training. That in private hospitals, the foundational clinical skills were neglected. For example, in a teaching session, a senior consultant justified CT over ultrasound in the initial evaluation of jaundice, saying this is what we do in our hospital. Revenue-driven values become embedded in training, and high costs of care are assumed as the best care, and financial success is promoted as a marker of achievement. Next slide. So we identified these 7 themes of market logic and erosion of clinical autonomy, a target-driven culture, overuse of procedures and diagnostics, high costs without quality, the adverse impact on health professionals, the evidence of resistance by health professionals, and the consequences for medical training. Next slide. So the key reflections are that corporatization has embedded market logic into healthcare in India over the last 30 years. Profit-driven priorities are overriding ethics and autonomy, and medical education is mirroring commercialization. There is growing alienation among healthcare professionals and evidence of deepening inequities in healthcare. While these are global trends, they are especially pronounced in India due to the weakened public sector. Next slide. So, in conclusion, we must reclaim healthcare as a social good and not as a commodity for profit. We must resist corporatization by rebuilding strong public systems, ethical practice, and accountability. And we must learn from and support each other across borders in our struggle towards healthcare for all in our time. Next slide. Thank you.
Thanks a lot, Anand. And you finished before time. And of course, in this brief time, you covered some of the most important themes which have emerged from the study, although it was a small study relatively, but it went into quite some detail, and we got feedback from dozens of healthcare practitioners from across different kinds of hospitals across the country. And I think it well complements the first paper, where we had taken more of a macro view. And I think that keeping both papers together, and I encourage you to read the actual papers because the panelists have had very less time to actually present. So there are many, many more facts and interesting quotes in the paper. But what we can see is that to understand the phenomenon of corporatization, it cannot be understood by a single level analysis. So only looking at the financial analysis, or only looking at the practices in corporate hospitals, either of these, or only looking at the technological and managerial transformations, each of these is a part of the picture, but in itself, it's not sufficient. So we need to do a multi-level analysis of the financial and economic level, the managerial and technological level, and also the practices and the social level. And the whole issue of social disembeddedness, which came up in Indra's presentation and in a different way, also in Anand's presentation, is also very important. That basically the entire, healthcare from being a socially embedded institution is becoming more and more financially controlled, and by the same token, socially disembedded. So I think these points have come out quite clearly. And another point I'd just like to remind before going to the question and answer session is that the scale is huge. It has come out to some extent in Satiki's presentation, but if you read in the paper, there are many more figures. So today, if you see India has the third largest number of dollar billionaires in the world after US and China. And among those $200 billionaires, 53 are from the healthcare and pharma industry, more than consumer goods, more than manufacturing. So that's the scale of, and that's why there are such huge financial investments coming in. into the healthcare sector. So we need to keep account of that, keep in mind this entire, scale. So now I think we'll open for a round of, so please, all the panelists, you can put on your cameras, and we'll have about 15 to 20 minutes of clarifications and on these papers. I have seen the chat box and sorry, the question and answer box. And within this, there are a number of questions. There are some comments which I think we will not, I mean, the panelists can see those comments, but we'll focus on the questions where there's some specific question being asked. So first of all, so one question is that what is luxury healthcare? So I'm not sure if we use this term. So will any of the panelists like to respond to this? What is luxury healthcare, at least in the Indian context? So Anand?
Yeah, I think the practice position, I don't, we usually think of corporate hospitals as hospitals where rich people go. But there are also players which are actually catering to, individualized healthcare, which I'm not very sure of. So we don't use this term very often of luxury healthcare.
Yeah, but to the extent that it is used in market terms, Satiki, would you like to add something?
So just what I wanted to mean that in case of India, you will find some hospitals look like big hotels. So you get certain facilities which are not directly related to healthcare, but the kind of facilities that are provided, just if you pay a much higher price for a particular procedure, you will get good cabins, and there would be a particular facility dedicated to an individual patient and something like that. And this actually may not increase the quality of the healthcare service, but it is something premium over and above that. And for that, the patient might be ready to pay additional amount or fees as a premium to the average price of the healthcare. I just wanted to mean that.
Okay, so we'll move to another set of questions. Abhijit has asked a number of questions. So I'll take two of those. What are the important effects of corporatization of healthcare on the public healthcare system? Was this studied in the present paper? And what are the reasons behind the regional disparities?
Okay.
Yeah, Indira, would you like to take this, about the impacts on the public healthcare system? You can unmute your mic.
Yeah. So, yeah, there are actually several interesting questions in the chat. I was trying to read them. Impact on public healthcare system. See, one is, I mean, we are not going into the reduction in the public health budget, because of which the public facilities themselves have a lot of problems. You see, I mean, the way to see it is how the conditions in the public health facilities became very poor, because of which a lot of people stopped using the public facilities. And along with that, then, so, there was this kind of push from the public sector to the private sector, kind of creating a demand, right? I mean, I won't go into all that. Uh, uh, we need to see it in terms of, how it has affected the functioning in public hospitals or the ethos in among public doctors. Yes, one major thing that has happened is doctors leaving public health institutions and moving to the corporate facilities, because the facilities there are better. No, that is why I showed those numbers. So more and more doctors choosing to work in the corporate hospitals, in these private hospitals, and so affecting then the availability of doctors for the public hospitals. The second, which needs to be seen, is the public-private partnerships, right? Where a lot of functions of the public hospitals are now being outsourced to these private institutions, right? Dialysis, diagnosis, diagnostics, many of these functions have now been outsourced by the public hospitals, right? So again, that is why, we need to see these public-private partnerships also. So overall, in one word, yes, it is eroding the public sector in many ways, this kind of growth of the private sector. Yeah, if that
Okay.
answers your
Yeah.
the
Another
question.
question is about the reason for regional disparity. So we saw that 68% of the investments have been in southern India. And most of the cities are in the southern India, which includes Tamil Nadu, incidentally. Somebody has asked about Tamil Nadu also. So what is the reason for this regional disparity? Satiki, Indira, and we also have other
So,
co-authors, incidentally, on the call. So Indranil and Sonia are also there, who are also co-authors. So you can also chip in case you feel you would like to respond to some question. So regional disparities, Satiki?
one is that regional disparity is not something very much specific about healthcare. The thing is that when the distribution of resources depends upon market, it will always be concentrated in areas where the growth has been, the earlier growth has been higher. So it goes to areas where the purchasing power of the people is higher, where the consumption expenditure is much more concentrated. So you will go to rural to urban areas, from small cities to large cities, because it is driven by profit making. So wherever I get the advantage of making more profit, the capital would move to those directions. And so it is true for hospitals, it is true for industries as well. We'll see that the regional concentration of industrial investment has also increased in the post-liberalization period. So that's the same reason what we see in healthcare. So it has moved to metro cities. I would say that there is one question which I want to answer, because it says that whether there is something in Tamil Nadu. It is there in Chennai, in Coimbatore and Trichy, and that accounts for 7.8% of the total PVC investment that has happened during the period which I have shown. There are one clarificatory question which I also want to answer, is that what is private equity investment and whether pension funds comes into that. Private equity investment is basically a capital invested in, mostly, which are big investments and which are made to unlisted or non-listed companies in entities which are not listed to public stock exchanges. So those kind of investments are basically long-term, they are big, and they source investments from different institutional investments or institutional sources, and pension fund can be one source of this private equity investment. So they basically try to, not only it is not an investment which is a short term, but they also try to come and influence the management and the institutional structure of an enterprise. So that is the specific nature of private equity investments. That's all.
Abhi, if I can,
Yeah,
so one
there are a
thing we
couple of
found
questions to you. Yeah.
In our interviews, we found that in the specific instance of liver transplantation, the liver transplantation in the private sector did not allow the development of liver transplantation in the public hospitals in Tamil Nadu itself. On the first question of how that the growth of the private sector is actually disallowing or preventing the development of specific specialty services in the government public sector. And the second thing that we are seeing is that the government is handing over public hospitals to private players and medical colleges, which is a recent a phenomenon which is exacerbating recently. On the growth, I think that it is, as was presented earlier, in the history of the development of the private sector, it's the start with the Apollo is very important. And we see that a large number of doctors who were going abroad, NRI doctors, invested back in the south, particularly in Andhra. And this phenomenon started historically in the south, which is related to other economic factors which have been mentioned. So I think the history of how this started is also important.
Okay. Uh, So because we have a number of questions, we have about 25 questions in the chat box. I mean, in the question and answer box. So I'll just move to a few others. So Rama Baru has asked about not all corporate entities are profitable. There are reports of a crisis within the private and corporate sector. Would you like to respond? So I think partly, Satiki, your slide on the contrast between the top 15 and the 274, maybe you can elaborate on that. So paradoxically, both can coexist. Please unmute your mic. Yeah.
So what I'm saying that of course there would be some corporate entities that may not be making profit. So in a market there would be profit earners, there would be losers also. Then only the market functions. And this is true also for other sectors where you will find that some corporates might be making losses. But what I would say that if we see that slide once again, first of all, there is a huge concentration of sales profit, as well as there is another slide. Okay, I'm not getting into that, but let us look into this. You'll see that first of all, there has been a huge concentration of sales, profits, and investment in the top 15 and top 100 hospitals. So they are basically the investors and the profit makers. Here, it is very interesting that we will see that during the COVID period, it is the top 100 and the top 15 companies. They actually made huge profits. But if you see the total hospital sector, which includes say 274 hospitals in India, which are listed, and there we will find that in total, in the aggregate, they're making losses. But these two segments, which are the top, they are actually gaining out of this process. And also, as I said, that they are making profits, which is always the advantage of big players. The small players cannot earn profits from financial channels because it is the big players who get the advantage of sourcing financial resources, which the smaller players may not be able to do that. And that is precisely the reason that in those cases, for the big players, we'll see that the share of financial resources, the last slide, if you see, the financial expenses out of total expenses are gradually increasing. We'll not see the same kind of graph for the bottom 15 hospitals. It will see in the top 15 hospitals because they are actually much more financialized compared to others because they had the opportunity to be financialized. They can mobilize resources through financial channels, and at the same time, they're participating and sharing through distributed profits through financial channels. So I would say that, of course, there would be corporate hospitals who would not be earning profits. It is not an uniform thing. Always it happens, it is in a heterogeneous nature. So the big hospitals are gaining out of this process as well, within the corporate hospitals as well.
Okay, thanks, Satiki. So Baba I has asked that what is the extent of foreign and domestic institutional investors in financialization and corporatization, and with pension funds, can workers or unions leverage on this in any way? This is an interesting question. So as we know that pension funds have also been a part of the, of course, probably not a major part, but some part of the funds. So Sahyadri hospitals in Pune and other parts of Maharashtra, it was actually the Ontario Teachers Pension Fund, which was the primary, institutional investors, which propped it up for quite some time until it was recently taken over by Manipal. So can there be some leverage which workers unions can have? And what is the so my hunch is that the scale of these kinds of funds is much smaller than that of private equity and sovereign funds. But Satiki and maybe even Indranil, if you want to chip in at any point, you can let us know. Yeah.
I would just say that pension fund is not always small. So you can have a countrywide pension fund, which can be accessed by private equity companies. So it is a huge fund which may be channelized to the health sector in different country. And it is not a small one. Now, the question is whether the health workers or the doctors who their pension fund in that particular hospital, whether that would allow them to to share their responsibility and their voice in the management, that is a separate question. So we should think that pension fund here is basically an institutional source of investment, which is coming from other sectors, which is accessed by the equity companies. And it is not the pensions which is related to the pension fund of, here also the pension fund may be managed by other companies. In most of the cases, our pension funds, there are pension fund managers, they are companies, they may invest. But I, as a worker or a doctor or a staff of a particular company, of a particular hospital, may not have the voice just because that I pay for the pension fund. Because the fund is accessed by a different company. If they invest, it is an investment of the company, where the worker would be completely invisible in this whole process. So I don't think that in this thing, this sharing of or accessing the voice or participating in management or influencing the decision-making process on the part of the worker is difficult.
Yeah. Thanks. Yeah. So Moga Kamalyani has asked that given the huge financial and political influence of these financiers, how can governments open their mind to the long-term dangers of this model of healthcare? And given the fact that it's in the context of overall lower economic growth, low reduction of aid, and so and high demand for care. So this seems to be like an easy option for governments in LMICs like India. So this is a bit of a broader question, maybe not directly linked to the content of the paper, but it's about policy options. Actually, several of the questions are about alternatives, what needs to be done, and so on. What can doctors do, and so on. So I'm not sure if we have the time to discuss those. Those are important points. So we'll have a second round of questions and answers after the next two presentations. So I think if anybody wants to respond to this, and there's one specific clarification from David Rowland. What is the metric you are using to measure post-tax profit? Is it dollar or percentage?
So, regarding the clarification of profit after tax, it is basically when we measure growth, it is growth in percentage. So not the so in this case we have measured what we have shown in our tables. It is basically a growth rate. So it is measured in rupees, and then you see this. It can be measured in dollars also, but the growth rate will remain same. Okay. So this is one thing. And can I say something about this larger question? I'll take 2 minutes, if you allow me. One is that I would say that whether the government is aware of this process of financialization, which is leading to this kind of inequality, and at the same time, it is leading to, I have not shown that, but it is in the paper that we will see that gross fixed investment in hospital sector is also show a decline in growth. But I would say that the government is basically allowing this process. And this process is being allowed with the hope that there are two things, that any financial process is always linked to a declining share of wages and salaries. If you see the macro picture, it is happening in India also. So you depress the wages and salaries, you pay for interest and dividends, and on the basis of what you can say debt financed or wealth financed consumption, you try to compensate the decline of the wages and salaries in the total income. So this is the macro thing which is there, on the basis of which the government wants to function. So you depend upon speculation, you depend upon financial channels, you have to only release the institutional, what you can say, hindrances to make profit. So this is the ideology of neoliberalism. I would not expect that the government would act upon that to reduce that. But if you talk about alternative, the first thing that needs to be done, which is mentioned in the beginning of this presentation on this panel discussion, inequality has to be reduced. The second is that the weightage of financial enterprises in the total economy has to be reduced, in the sense that those are real productive sectors, their share in the total economy has to increase. We'd also have to reduce if you see that star doctors and the junior doctors, and this is not only in healthcare but in other sectors, the difference between the top salary and the bottom salary has increased like anything. That needs to be reduced. So there has to be a demand management on the basis of which this can be moderated. And rather than depending upon profit, which is dependent upon financial channels and speculation. So these are some of the few things I thought would be important.
So I think we'll now need to move, because we've completed 20 minutes of this round of clarifications. So a last response from Indira, and then we'll move to the next two panelists.
Right. So there really are a lot of questions in the chat box. Not all those aspects have been studied, but from an earlier study and from our witness seminar report with doctors. So we have discussions with another set of doctors in Bombay-Pune region. So we can share those really, because due to lack of time here, so this is the second study which Dr. Anand has shared, but we have had similar findings. And I have tried to answer some of the questions in the chat box. Somebody has asked about regulation. You see, I wish to quickly highlight that as part of the World Bank health sector reforms and all this project of privatization, regulation was to be an important part of this whole health sector reforms. In fact, during the witness seminar, doctors in Bombay shared it. In fact, a health administrator did share about their experience of regulation. And that is one thing that has not been enforced at all. What is being implemented is only getting the private sector to grow. That is something we need to keep in mind. So as Satyaki also said, the whole policy push, what it is emphasizing and what it is not emphasizing. So you see, so regulation, there can be a separate webinar by itself on why it is not being implemented. The Clinical Establishments Act and the journey. We had a witness seminar on that, on the journey. Abhay was there. So it is always being, pushed to the sidelines. Yeah, those are my points.
Okay, so due to a bit compression of time, there are several other interesting questions. So maybe in the next round, we'll try to take some of them. There are questions, several questions, which I'll not now go into now. But in the meantime, as the panelists speak, if any of you want to reply in the in the question answer space itself, please do that. Yes. And if some questions we cannot answer right now, we'll also try to answer over email in that. So now we move to the next two panelists speaking from the international perspective and bringing, so as we have said, this entire webinar is not just about India. Of course, the focus is on the Indian case study, but the phenomena of corporatization, financialization of healthcare are very much global. And so we would like the global perspective also to be brought in. So we have with us Anna Marriott, who is an independent advisor and who has previously been the public health policy advisor at Oxfam International. And she has done extensive work on and research on the role of DFIs, development financing institutions, in the health sector across the world and also in India. So Anna, please come in with your, as a discussant on the role of development financing institutions and any other points which you'd like to share. Anna.
Thank you so much, Abhay. And yeah, thank you for inviting me to this. I don't know whether my presentation is available yet. So, I mean, before I expand on the role of development finance institutions in all of this, I just wanted to first say how valuable I think these two papers are, and especially, as Abhay said, when presented together, on the one side, giving that detailed analysis of the increasing penetration of powerful private financial actors into the healthcare system, that increasing concentration of ownership, profits and power in the hands of a few mega corporations within the sector. And then the other, most importantly, in my view, paper revealing how these powerful financial interests translate to truly disturbing practices behind the hospital curtain, both for workers and for patients, in order to maximize shareholder returns. So just a big thank you from me for the work that's gone into that. And the second point I wanted to make actually is a request to the authors, and that's really to share your methodologies in more detail. And I'd say that not in the usual academic way, but actually as a very practical step-by-step how-to guide, so that this research can be replicated by others, whether academics or activists or anything in between, because I know that there is demand, there's a thirst to do this research in other contexts, and many of us working within the health sector don't necessarily have the expertise to do analysis of these corporations and financial actors. But also, I would say the really innovative methodologies used for the qualitative research, getting these testimonies from workers, from patients, is really not easy. But I think they are the most powerful evidence that we can bring to the table if we want to bring about change. So yeah, I'd really urge you, the authors, to share that methodology in more detail. But my main task today is to talk very briefly about the significant role that development finance has played, and particularly development finance institutions, in transforming India's healthcare system, but also more broadly across the global south. And on this, I'll mention 5 things. Firstly, that this role has been incredibly significant. Some of the development finance institutions have been there from the start of this transformation of healthcare system, and have been a very much a driving force. Second, despite their significant role, it has been largely hidden from view. Third, that it has caused enormous harm, both in terms of the role of development finance in the broader transformation of healthcare systems in India and elsewhere, as has been described, but also in the form of systemic human rights abuses in the specific hospitals that the development finance institutions are funding. Fourth, that this is all happening in a vacuum of accountability. And finally, that while India really does showcase the very worst extremes of development finance institutions' behavior in this sector, these same institutions are already very advanced in penetrating the healthcare systems of other countries across the global south with similar terrible consequences. Next slide, please. So most of what I say here draws on 2 Oxfam reports, and because I can't go into very much detail, I would encourage you to read those. The first is a global report looking at the role of 5 development finance institutions in healthcare across the global south. And the second shines a light specifically on the nearly 3 decades role of the World Bank's DFI, has already been mentioned, the International Finance Corporation, that has invested heavily in India specifically. And I should, I think, first explain for those who are less familiar with what DFIs are. These are government-owned or partly owned and financed development banks whose mandate is to promote and invest in private sector development in the global south, but also to help achieve the Sustainable Development Goals, including universal health coverage. They can be multilateral, like the World Bank's IFC and the European Union's European Investment Bank, or bilateral, like the UK's BII or France's Proparco. And the broader investment role of DFIs in low and middle income countries dates back decades in some cases, but their role in healthcare really only grew since the late 2000s. And with the IFC, I mean, this is the exception, with the IFC's role in India actually goes back much further, to as early as 1997, when it made its first investment in Apollo. And I really do need to flag here that IFC, so the private sector arm of the World Bank, since that first investment has really led the charge in promoting the commercialization and financialization of healthcare in the global south. This is both in terms of the scale and scope of their investments and their extensive use of financial intermediaries, but also critically in leading the global development narrative as to why these investments are needed, in their view, and how they achieve win-wins for both investors and in terms of the development and growth of healthcare systems. Most of the DFIs publicly claim that their investments in healthcare will improve access and boost universal health coverage, but objectives about company growth, mergers and acquisitions, as well as employment, are also often present and given much greater prominence in the detail around the objectives for these investments. Although I would say those details are always pretty light. The broader DFI narrative about objectives explicitly talks about these investments helping to crowd in private finance. Essentially,
just a second, Anna, are you changing your slides?
I will in a minute. It's okay. I haven't got many.
Because you're still on the first slide. Yeah.
So they actually explicitly talk about the objective of crowding in private finance. So essentially, they are talking about an objective to financialize healthcare with an assumption that this is a beneficial course of direction. And this is exactly what they do. And my research at Oxfam uncovered over $2 billion in direct investments in the health sector from just 4 European development finance institutions. But we also found that these direct investments were a minority. In fact, over 80% of their investments were made via financial intermediaries, mostly private equity funds. Next slide, please. So what we did find is that India has long been the most popular destination for this, investments from the development finance institutions. And in 4 of the 5 DFIs that we studied, the highest proportion of health investments was in India. For the IFC in 2016, 28% of the IFC's health portfolio was in India. And we know that they've invested nearly $500 million in India since the late 90s. And in terms of number of investments rather than value, India made up over half of the UK's DFI health investments. Next slide. For the other DFIs, because the overwhelming majority of their investments are made via financial intermediaries, we actually can't put a dollar value to them. But for those who are interested in looking in more detail, there's an annex to one of the Oxfam papers that lists all of the intermediated investments made by the different DFIs up to 2023. And there will be many familiar names in there. But it's not just about the volume. IFC, as has been mentioned, has been a repeated investor in the likes of Apollo since the late 90s. And it really has chosen to handpick and handhold the biggest, most well-recognized and dominant hospital corporations in India, the likes of Fortis, Max, and others, through their growth journey, swallowing up other smaller companies and growing their market share and profit margins all the while. The UK's DFI has done likewise with Narayana, frequently using Narayana as a poster child of so-called impact investing. It's also been a massive investor in Manipal. And the backing of these government-affiliated or government-owned development banks gives legitimacy and status to these corporations. It says that they are safe to invest in. And as I say, this is an explicit aim of the DFIs, to help these companies attract even more private financial actors to invest. And the evidence is clear that these powerful private financial actors have followed IFC's lead. But this is, next slide, please. But this is all very much hidden from view. And it's also money that's hidden from tax authorities. This diagram is one of a hospital in Nigeria, but it could just as easily be a hospital in India. And it traces the very complex web between the multiple investments made by the DFIs to a hospital via this web of complex financial intermediaries. And our mapping of these webs has shown that these financial intermediaries are all domiciled, or nearly all domiciled, in tax havens. And as I say, this web for one hospital is replicated across so many of the hospitals that we identified through our research. And it makes it incredibly difficult to follow the money, incredibly untransparent, really hard to identify who is benefiting from this, from these financial flows, and from any abuses and harms that the hospitals are complicit in. And I will turn to those harms now. If you could go to the next slide. So Oxfam's primary research in India and our secondary research across the portfolios of the DFIs that we studied identified a systemic pattern of patient harms, exploitation, and abuse. In India, our research collated testimonies of patients and their families relating to treatment in care hospitals and Narayana. But across all of our research, we identified several cases of patients imprisoned in these private hospitals until bills were paid, patients entitled to free care pushed into poverty by fees that they should not have been charged, emergency medical care denied at the doors of these private hospitals because people were too poor to pay, people pushed to have unnecessary treatment and surgeries, extensive profiteering during COVID with significant evidence across India, but also across other countries badly affected by the pandemic, including Uganda. And also systemic evidence across the portfolios of the DFIs that services like maternity care are incredibly expensive and way out of reach, really countering that idea that these investments are helping to reach people who can't access healthcare. And the evidence is incredibly harrowing and distressing. But what is equally disturbing is that these stories of patient harm and abuse are incredibly easy to find. We could go to the next slide. There are court cases, high-profile media cases. Everybody in India knows that these things happen on a daily basis. Yet how is it that these multi-million-dollar development institutions that have invested in these companies over years have not identified these problems? Why have they not investigated and acted? Or do they know about them, but they're just choosing to look away? Next slide, please. And this is where the accountability is totally lacking. What is evident and has been revealed by several journalists at this point at both Bloomberg and the IIGH and several others, with a brand new investigation out actually just today on a fraud case in an IFC-funded hospital in Kenya, is that the due diligence of institutions like the World Bank's IFC has not only failed to look for these issues, but when problems are identified and reported to them, they have failed to act. They have chosen to look away. And instead, they continue to invest in contexts where there is no way that they don't know that these harms are happening. And they know that the regulation is entirely lacking to protect patients and healthcare systems from these harms.
Anna, you need to wind up now.
Yeah, I'll just conclude the final slide. So since Oxfam published its research in 2023, it's worked with many civil societies across the global south to push for accountability of the DFIs, but we have only seen tiny insignificant shifts so far. The IFC, for example, has said that going forward, it will require healthcare investees to sign up to an ethical code of practice. But the truth is that this code of practice already pre-existed this announcement. And in fact, many of the hospitals complicit in these scandals, the likes of Apollo, Fortis, are already signatories to that code of conduct. It is toothless And given that this is the only real announcement the IFC has made about the changes it's making, it's incredibly disappointing. This final slide summarizes the call of over 70 organizations for the role of the development finance institutions in the financialization of healthcare in the global South to be stopped, and that the harms caused by their investments fully investigated and remedied. Thanks ever so much.
Thanks a lot, Anna. And you have so much to say and probably also much more. But in the interest of time, we had to sort of wind it up. But I think what you have brought forth so sharply is that, and which addresses some of the questions also, that governments are centrally involved. They are not peripheral. They are not, ignorant. They are not just passive spectators. Developed country governments, through their development financing banks, basically, are actively pushing not just investments, but also the creation of markets, the expansion of markets, and the entire corporatized healthcare kind of environment through their investments, and as well as other types of advice which they are giving through public-private partnerships and so on. And that is being actively, of course, quoted by the government of India and other governments in LMICs. So DFIs have played a very pernicious role, I would say, in this entire process. So thanks a lot, Anna, for the detailed presentation. So now we come to our next and last and very important panelist, Professor Leonardo Matos, who is a professor at the Federal University of Rio de Janeiro. I cannot pronounce it in Portuguese,
It's fine.
but that's what I gather. And he's also a very active member of the People's Health Movement, not only in Brazil, but also at the global level. He's leading the working group on financialization and corporatization of healthcare of the People's Health Movement. So Leonardo, over to you.
Hi, Abe and everybody. Thanks so much for the invitation, for being here today. First of all, I would like to acknowledge all the effort that this group have done in this case studies. I think they really add a lot of questions, of more interrogations, and a lot of elements for us to think in this global problem that affects our countries in many different ways, in different ways, but definitely a global process, especially for the countries in the global South. So just before I start, I would like to make some comments. I think that many of the aspects that were presented here today have close relations to what's happening in Latin America, especially in Brazil as well. Yeah, but I just would like to point that this comment that I'm going to make is based mainly on some research that we have been conducting here in Brazil as well, in the research group on healthcare corporatization. We have been following the private sector in healthcare, in Brazilian healthcare, since the early of last decade, the 2010s. And yeah, and since then we've been following very closely all the changes and transformations going on in the Brazilian health system. So yeah, after this webinar, for sure, we have a lot of things to share and to discuss with you regarding methodologies as well. We've been following closely a lot of companies here, and as we've seen in other presentations, information and transparency is a huge problem for us to study what's going on. So just a very, very brief background about the health systems in Latin America. It's important to know this. For sure, I cannot go deep on that, but Latin America have highly fragmented and segmented health systems. Usually high-income and formal workers counts, high-income people and formal workers count with private healthcare or social insurance funded by public sector. But a big part of population usually relies on poor quality and underfunded public programs. For sure, there's a lot of specificities in each country, but especially in countries like Chile, Colombia, and Mexico, the neoliberal reforms associated to the structural adjustment really reshaped the healthcare system and promoted private capital in this health system. But also, it's also important to notice, but even in the case of Brazil, Brazil didn't follow exactly this neoliberal agenda. Actually, Brazil made a health reform in the late 80s that intended to build a free public universal healthcare in Brazil, the SUS, Unified Health System. And we really had a lot of improvements in our health conditions and health system due to the implementation of SUS. But on the other hand, this doesn't mean that Brazil was a part of all this other process, because private markets were also stimulated and developed during these last 30 years, especially the health insurance industry, that which is I think it's very key for Latin America to understand all the financialization dynamic, because the private health insurance industry has a key role on concentrating resources and taking these resources to different private companies, not just insurance companies, but hospitals, diagnosis, laboratories, and so on. So yeah. What I would like to share just a few recent cases in Brazil, especially. We recently, in the last 10 years, we saw the rise of two dominant corporate and verticalized health groups. Door chain, which was originally a hospital chain, boosted by private equities funds and also by national capitalists. And this firm had just one hospital in 1998, 17 hospitals, 27 hospitals in 2015, and now it has more than 75 hospitals, 61 oncological clinics, more than 11 diagnosis laboratories, and so medical schools and so on. So it became like a huge corporation, putting together health insurance, hospitals, clinics, diagnosis, and a lot of other services. So a very diversified company. And this company was boosted before by private equity funds such as the Carlyle Group and also sovereign funds, as the Singapore Sovereign Fund. And recently in 2022, it merged with a health insurance company here, SulAmérica, and so they became like a very dominant player. But focused especially in high prices health insurance. Their focus is to raise prices as much as possible because they are focused on the high income segment. So their focus is like oligopolizing some markets and also rising prices of insurances and of medical service. And so on. On the other hand, we also had the consolidation of another very important group, which is named Hapvida. Hapvida was a regional group that implemented at first a very low-cost verticalized model of health insurance and verticalized insurance and provision, focused basically on low middle-income patients that also used the public health system, the SUS. And this company got very big internally without any private equity fund in the last decade. But in 2019, it made an IPO and merged with another similar company, Notre Dame, which was boosted by Bain Capital private equity funds. So these two companies, they have developed two different models, but both models are competing with the public health system in different ways. So this is part of a recent research of a colleague of us, Frederico Haddad, who is showing that, for example, Hapvida uses a model that is based on excess denial and judicialization of health demands, and also the transfer of risks to the public health sector. While Reddor, the other company I mentioned, they compete with us with the public health system for funds and also for professionals and also for hospitals that provision services both for private insurance and for public health systems. So we clearly identify some patterns of competition, and these groups became so big and very, very influent in the country. Another example that I would like to share is just a very recent example and a concrete example about medical schools in Brazil. we had a lot of public policies in the last decades boosting private schools, not just for medical schools, but all type of private universities. Especially after 2014, there was a specific public policy directed with the focus on expanding the access to medical education in Brazil. And this policy was based mainly on expanding private education. Recently, last week, a result of a national exam of the medicine courses showed that out of 350 medical schools, 1/3 had an insufficient result. Like out of 5, these institutions had took the grade 1 or 2 in the exam, which means that their doctors they are putting in the market are not able, they are not skilled, they are not able to provide any type of care or any type of quality care. So this is becoming a huge problem, and it's very interesting to notice that the best grades were in public universities, while the worst grades were in private for-profit companies that which are in the last 10 years also they had a lot of boost of private investment funds. They become big corporate groups as well, and they are making a lot of money based on public subsidies and so on. So yeah, that's a very concrete recent example on how financialization is also taking control of medical education and so on, and clearly showing that the quality of care can be really in danger in this context. And well, as I don't have much time and to go deeper in some cases and examples, I would just like to share a few reflections based on our experience here. First of all, is that it's very clear to us that financialization does not invent new markets or new things by itself. No, financialization really relies and depends on pre-existing healthcare markets created or shaped by healthcare policies and reforms for sure. And they seek this. They go for these markets looking for opportunity of risk diversification, right short-term returns, speculation, and safe spaces during economic crisis and economic instabilities. So this is also a very important point. Like in this crazy international context, healthcare assets can become even more attractive for finance capital due to all the uncertainties in the world scenario. There's also a high correlation on how healthcare is organized and institutionalized in each country and how private finance penetrates in different health markets. So it's very, very important to make country-specific studies and to area-specific studies, because otherwise you can just generalize a lot of things and without going deep into the specificities of that. And financialization is not a phenomenon that just provoke common process. The impacts are very diverse and very heterogeneous in different contexts. So we really have to have a focus on that. We also understand that financialization becomes not just an opportunity for financial investors, but also for they become a competitive advantage for local corporations. These local corporations find new ways of financing, enabling business leverage, verticalization, internal growth, diversification of activities, and so on. So local firms also actively seek to participate in this financial dynamics. It's not like a process that they are passive in, or the financial capital just comes from abroad and dominates everything and changes the local markets. No, local firms are really directly interested in that, because this is a competitive advantage in their markets to join this financial dynamics. So, and also I think this is also very important to share, is that much more than a domination of finance capital over productive capital in the Brazilian context, it's very clear to us that this is an association of those capitals, and both capitals gain different things from that. And just in economic terms, but also in political terms. Going to the end, we also see that this process also creates a bigger influence of private sector over health policies, states and governments. So this convergence of interests of private, local enterprises and financial sector really create barriers to public health care. For example, in the case of Colombia, we are seeing this very clearly now progressive reforms there are being contested by the private sector, which is financialized in different ways there. So it's not they were going to contest that anyway, but because they are financialized, the corporations, they have much more linkage with financial investors, they become more powerful to resist to progressive reforms and to progressive policies. And also, it's very important to notice that in our national context in Latin America, there is very, very poor regulation capacities and innovations to deal with this context. We see that our regulation agencies and our governments are attached to a vision of markets that it was from 20 years ago, and they just cannot capture this dynamic passively or actively. They don't want to capture that. But we really lack instruments and policies that are effectively dealing with these problems in different countries. So it's very important to broaden the discussions for us to understand which mechanisms could be used for that. And to finalize, just one last remark, is that it's very important to understand that it's not possible to address the problem of financialization alone. Privatization and stratification is very, very closely related to financialization, and nowadays they cannot exist one without the other. So we really have to build new narratives and to denounce this perverse combination that dominated the international discourse, that universal health coverage and privatization can be combined in a good way. So if you really want to rediscuss again universal health care and the right to health, you really need to build a new narrative that combines universalization with deprivatization and protection from financial markets as well. So otherwise, you're just going to keep seeing all these things happening without proper responses. So yeah, for sure, we had other things to comment, but the time is already gone. So let's go to the questions. Thank you very much.
Thanks a lot, Leo. This was a very useful reflection from Brazil and Latin America. And many of the points sound similar, although, of course, there are many different kinds of health systems, even within Latin America. But the story of financialization fueling the growth of corporate healthcare, and not just corporate hospitals and chains, but also other fronts of penetration of the finance capital into all different parts of the healthcare system, and which also includes the pharmaceutical industry, the medical equipment industry, private medical education, health insurance industry. So these are all operating in a complementary or whatever sort of mutually reinforcing manner. And that is why even in India, the process of corporatization of healthcare is not limited to corporate hospitals. It is actually influencing the entire healthcare sector, including charitable providers, including small and medium providers, including even the public health system. So in different ways. So of course, that's a matter for a further discussion. So now I think we need to move towards the last round of a few more questions and discussion. And then David will be doing the winding up. So now any specific questions related to what Anna and Leo have talked about? And we'll of course take a few more questions from the chat, from the question and answer box. 2 or 3 questions have come about regulation. So maybe Anna, you might like to respond to this question. If such DFI funding, has been regulated, and if such DFI hospitals have been regulated, which aspects have been regulated? So has private healthcare been regulated because they have received funds from DFI? Abhijit has asked a couple of these questions about regulation.
Thank you. I mean, the simple answer is no. As we understand it, when the IFC or the other DFIs do their due diligence, they take into account a number of risk factors around that company, but that largely, and including environmental and social risk assessments. So there are a number of indicators and criteria that the DFIs will follow to ensure in theory, that these companies are not going to cause harm, whether that be environmentally, whether that be on labor rights, etc., etc. But these are quite light touch processes. When we try to get into the weeds of whether there is any conditions placed on these companies by the DFIs, it became quickly apparent that conditionality is incredibly hard for the DFIs to introduce. For example, we asked, would there be any conditions like making sure that prices for medicines or treatment don't go above a certain threshold in the hospitals that you're investing in, given that you're saying that these hospitals will reach low-income patients. They almost laughed at that suggestion that they would have any ability to implement such conditionality. So the short answer is no. And not only that, so not only are they not able to place, well, they say they're not able to place these kinds of conditions on performance processes, policies of these hospitals and healthcare providers, but they're also playing a very damaging role as an institution, the World Bank that is, on the broader regulatory framework. So, you know, the World Bank has been very much at the heart of advising governments to deregulate and to make access to these markets much, much easier for various financial actors. So actually, I think they've been a real force for harm on that front as well. So the behaviour acts on both levels. I will say there's a caveat. So I mentioned at the end of my presentation that IFC has these ethical principles that were a voluntary code of conduct that healthcare providers would sign up to. It's signed up to itself. It's now saying that this will be a condition of future investments, that corporations sign up to these ethical principles. But as I said, well, they're incredibly light touch in and of themselves. They don't go into much detail. And clearly, the hospitals are violating these principles on a daily basis, and the IFC is doing nothing about them. So, yeah, sadly, the regulation is pretty absent on the part of the DFIs themselves.
There are other couple of questions by Malu Mohan. So one is about, do you see transparency in governing these transactions, basically investment transactions? And can the public insist that any hospital empaneled by PMJY, which is the large government health insurance scheme at the national level, must mandatorily disclose financial intermediaries and PE funds? So is there any mandatory legal provision that private hospitals in India need to disclose their investments from PE funds and other funds? To my understanding, probably not. I'm not aware of that, at least, but others can also comment on that. And his other question is that, can you share any global cases or instances? And Leo, we look towards Latin America to some extent for relatively progressive governments. But of course, you have a probably more balanced view about that. But maybe you can respond to this, where states have course corrected and brought in regulations to contain corporatization and financialization in healthcare. So both Anna and Leo, we have heard a lot of the negative aspects and the gloomy picture. But are there any governments which have brought in any kind of regulation to contain, maybe not completely reverse, but at least contain or regulate corporatization and financialization in any form? And I think, David, you also might like to comment on that one.
Yeah, unfortunately, I don't have good news in this field as well. Yeah, what you can see, I mean, in some countries that I follow up more closely, is that even when you have progressive governments there, don't have like strong policies to regulate private sector or to change the scenario. I think the most recent example of a try is related to Colombia. Now, Colombia was really trying to, President Petro was really trying to reform healthcare there because they had like neoliberal reforms in the 90s and the 2000s. They created a lot of so-called health enterprises there. And these enterprises are really hindering the right to health in Colombia in different ways. And President Petro was really trying to make a reform there in terms of controlling better these companies and also making the access universal and not stratified between different companies and social groups and so on. But this is finding a huge resistance, not just by the companies, but also by the legislative, the executive powers and the judiciary. So actually Petro tried hard to do that, but he couldn't advance so much in this area. In Brazil and Chile, for example, I see that these things are very naturalized, even for progressive governments. In case of Brazil, we have the public health system, which is a strong public health system, but for sure underfunded public health system. But usually the progressive forces concentrate much more on what's happening in public health system, and they keep an eye away from what's happening in private healthcare. But in the end, it's a political challenge for us to convince people that both things are closely related. You cannot just deal with one problem without dealing with the other. But there's still a long way of convincing, including progressive forces, of this is as a political problem. You know, in Chile, we also had recently in 2019 huge contests, protests, and so on, contesting the pension, the private pension schemes, and also the private health care schemes. But the last progressive government couldn't do much about that as well, due to the political contest and the opposition forces, and also because of government choices. So yeah, we still have to find good cases to inspire ourselves on that.
Yeah. So what I gather, and of course, maybe David, you can come in here, that the whole phenomenon of private equity playing such a major role in healthcare systems and the processes of financialization and corporatization have often remained sort of below the radar, for progressive civil society. And perhaps governments have also treated this as something which Leo has called normalized. So this is okay, it's part of the process of overall open markets and so on. So the perverse and damaging impacts of financialization and corporatization have not yet been as visible and as well recognized as they probably should have been. So now perhaps is the time to wake up, even if it has not happened until now. Definitely. So as I gather, maybe you can share also about in the US. Yeah, although it's not maybe a very good example as a country right now, but there are a number of state governments which have brought in, regulation of, corporate practice of medicine kind of legislations, and there is some sort of attempt, maybe not very successful yet, but at least there's a recognition that corporate practice of medicine is a problem which needs to be addressed and needs to be dealt with. So, David, would you like to add anything on that?
Yeah, I'm glad you mentioned the American states that are trying to address this problem through regulation. But I think you're also pointing to the kind of broad public discourse and narrative around private investment. And it's not just that there's a lack of awareness of these harms and the systemic harms in particular. We perhaps know more about examples of patients themselves being exploited or abused, doctors and health professionals also being treated badly in certain private hospitals, but the systemic impacts, the overall functioning of the health system in terms of its efficiency and its effectiveness, these are certainly things that are not being properly and adequately studied. But I think worse still is that the current narrative is actually looking to private investment as a solution to the problem of public insufficiency, public budgets being inadequate. So private investment is now being touted as a requirement for meeting the SDGs, and it's being kind of framed as a positive solution. And this is something, again, that we need to dispel, thinking very very strategically about how we communicate this, because it is a subtle argument to be making when we know in many countries the public sector is also dysfunctional. So we've got to be connecting this issue also with wider issues about restoring the public sector, addressing issues around debt, and also thinking about the way in which governments can raise more public revenue through reforms of the tax system and through more progressive tax policy. So I think what Leo was saying is absolutely spot on. We can't just look at one part of the picture, but we have to have a kind of holistic response to this issue.
Okay. So I think I tried to address several of the questions, maybe not all of them. So there's one question from Baba I about the place of IFC as a key DFI, but what about regional developmental banks like the Asian Developmental Bank and maybe others? So any comments on that? And Leo, for you, Lakshmi's question is about the Latin American social medicine, like Alamis probably she's referring to. So any role which has been played by progressive medical education and so on in resistance against financialization and corporatization. So Anna and then Leo.
Yeah, I mean, before I answer Baba's question, just to also mention the case of South Africa in terms of a government that is trying to course correct, referring back to that question, in that, I mean, in fact, the South African government hosted a session, used its G20 presidency to host a session during the health G20 summit to discuss and present some of this evidence around the harms of financialization. And the South African health minister himself presented the really troubling situation in South Africa, an incredibly financialized healthcare system, an incredibly unequal healthcare system where the lion's share of the public budget for health is subsidizing private health insurance for a minority of the citizens. But the South African government has tried to introduce legislation for a universal system and is being taken to court by financially backed corporations in the healthcare market to try and block those policies coming to fruition. So there are governments trying, and I would really congratulate the South African government for making an effort to put this topic at the heart of international debates, and I think we need to work with them and with others to generate more debate and profile more of this evidence in the right spaces. Just on the regional banks, Baba, this is an area where when we started out our research on DFIs, really there had been no digging as to what role they were playing. And it really felt like the next step in that research should be the regional development banks. We know that they're present in many of the same investments that the bilateral and multilateral DFIs are involved in, but they may well have an entirely separate portfolio as well. And it's something that really does need further research and interrogation.
Leo, any comments on the Latin American social medicine, its role in resistance?
Yeah, that's a good question. We are very proud of what we have been doing in terms of critical thinking in health and all the Latin American social medicine movement. And this movement has really provided a generation, different generations of fighters, of intellectuals looking for a counter-hegemonic view of health and healthcare. So for sure, this movement have been fostering alternatives and critical groups in all the continent across the decades. But still, we are a counter-hegemonic group. We are even when we are a part of progressive governments, there's a lot of difference between government policies and what the social medicine movement demands. And even in countries like Brazil, where we have like the strongest maybe movement related to social medicine, there are some difficulties. So I would say that we have that social medicine stimulated groups all across the country, the region. So you can find groups resisting to privatization everywhere, but still a very difficult thing to make this totally alternative and hegemonic view of health and healthcare in the region. So yeah, but the fight continues. That's it.
Okay, so some of our co-authors of the papers are also there in the session, although they're not among the panelists. So Indranil and Sonia are also co-authors for the first paper, and Gayatri and Aparna are co-authors for the second paper, which was presented by Anand. So in case you want to add any points before we wind up, any of you as co-authors, please, you can just raise your hand and we can ask the organizers to unmute you and you can speak. Aparna, Indranil, Gayatri, Sonia, I hope you're there. I think Indranil is not there. Okay, so in case you want to come in, please do that. So I think we have just opened a conversation today. There are, as Indra has written, this is an understudy topic. There are many, many more things to be studied. So I'd like to, before moving towards concluding, share 2 points which are forward looking. So the first is that with support from UNU-IIGH, we are now doing a second round of study on corporatization and financialization of healthcare in India. And we are in the process of conducting in-depth interviews of various key informants across the country, various kinds of key informants and respondents who have direct experience of or exposure to corporate healthcare. So any of the doctors, healthcare professionals who are on the call today who would like to contribute, definitely we can consider that. We have already interviewed more than 35 such respondents across various regions of the country, but we are still continuing this process. So we would like you to, if you're interested, you can put it in the chat box, your email ID, and we will get in touch with you if you would like to contribute to this study. Even otherwise, not just as a respondent, but definitely as a respondent. So this study is ongoing. And the second is that we would not like to just stop at a study. And David can also add about this, but we are planning a national symposium on corporatization of healthcare in India later during this year, and where we will be putting together both these papers and the ongoing study and the entire body of evidence which is there, and now moving towards the counter narrative. So this is the critique, which is very important, because unless we have a well articulated and evidence-based critique, we cannot move to the next step. But then probably we'll also try to put on board and have a dialogue with multinational, multilateral agencies, even perhaps with, governments, state governments, and the union government to the extent that they are interested, and other stakeholders, about what needs to be done. Because obviously, besides general strengthening of public health services, which is an ongoing agenda, so that's given. We'll keep working for, and demanding that. But above and beyond that, what needs to be done specifically to regulate, control, and address financial investments, corporatization, their practices on different fronts. We'll be taking up some of these things in the symposium. So thanks a lot to everyone. And David, now maybe you can give the concluding comments.
Yeah, I won't do concluding comments, but I'll do some concluding thank yous. Firstly, to the audience, especially those that have managed to last this marathon 2-hour webinar. Thank you for staying online. We didn't manage to respond to all of the questions that were placed in the chat box, but what we will do is to download them and respond to all of these questions in writing, and we'll be emailing all of you with a fuller response to the questions that were in the chat box, and particularly those that weren't addressed during the webinar. Secondly, I just want to thank you, Abe, for organizing this and moderating this and being an excellent ringmaster. And then finally to the panelists, thank you, Anand, thank you, Satyaki, thank you, Indra, thank you, Leo, thank you, Anna. And thank you to the UNU-IIGH team behind the scenes who've been working really hard this evening to pull it all together from the IT side. But yeah, as Abe says, this work will continue. It's an incredibly important set of issues, and there are many people who are interested in what we're doing and the kind of topics and issues that we're raising. And as Abe said, even in the US, the situation has been so bad that there is a recognition from doctors and state governments that something needs to be done to course correct. So we must go forward with positivity and optimism that we can change some of the harmful effects of financialization. So with that, thank you once again, and good night to everyone from Malaysia. Bye.
Bye.